Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to this activity from Emirates Cardiac Society. My name is Firas Al-Badarin. I'm a cardiologist and a multimodality imager from Cleveland Clinic, Abu Dhabi. And I'm also the head of the imaging working group of Emirates Cardiac Society. It gives me a great pleasure to welcome you to another exciting event that brings to you updates and new developments in a very exciting area, particularly hypertrophic cardiomyopathy. It is my great pleasure to co-chair this event with my friend and colleague, Dr. Nadia Al-Matroushi, and to bring you this activity on behalf of the imaging and heart failure working groups of Emirates Cardiac Society. Tonight's program is going to be entitled Hot Topics in the Diagnosis and Treatment of Hypertrophic Cardiomyopathy. As always, we've promised to bring to you exciting updates, a very dynamic agenda, and a group and a lineup of speakers who are experts in their areas and will really break down this information to you in a clinically oriented and valuable way that hopefully you can use in your practice. So without further ado, I'm going to turn it over to my colleague, Dr. Nadia, who will co-moderate the first part of the webinar and will introduce the first speakers. Dr. Nadia.
Assalamu alaikum everyone, and thank you, Firas. So it's my pleasure to introduce the first speaker, Dr. Hussam Ghalim. Is consultant cardiologist specialized in advanced heart failure and transplant. In his the medical director of mechanical circulatory support, and he will discuss about the HCM essentials from mutations to clinical manifestation.
Thank you very much, Dr. Firas and Dr. Nadia, for this kind inclusion. So I was given the kind of difficult task of talking about HCM essentials. Well, there's no real essentials. It's a very diverse and deep field, but I will try my best to delve into this. I have no financial disclosures related to this topic. So the outline will be talking about genetics of hypertrophic cardiomyopathy, delving a little bit into the histopathology and diagnosis, and then just briefly mentioning some of the adverse pathways in hypertrophic cardiomyopathy that will be touched upon during this seminar by some of the other speakers, and then summary and take-home messages. So hypertrophic cardiomyopathy is extremely common worldwide. This is data showing that the prevalence can be in 1 in every 200 patients, 1 in every 200 individuals, actually. So it's much more common than any other cardiac condition. And as you can see here, it's much more common than dilated cardiomyopathy and some of the other cardiomyopathies that exist. So it's something that a cardiologist or even an internist will run into in their usual practice pretty frequently. So the mutations involved in it really relate to the cardiac sarcomere, which is the basic unit in the myocyte, the cardiac myocyte. And it is really comprised of the thin filaments here and the thick filaments and how they interact. And most of the mutations involved in hypertrophic cardiomyopathy, and we'll hear about them later on in the talk by Dr. Firas, relate to mutations in the thick myofilament proteins, the myosin heavy chain 7, as well as the myosin binding protein C. So those comprise about 40% of the mutations are in the thick filament component, while the thin filament component, some of the TNNT2s comprise about 5%, so much less likely. There's also other genes involved, and we'll look into them in a little bit. The inheritance of these mutations is all autosomal dominant, meaning they tend not to skip a generation, and meaning that if all you need is one allele to be affected for an individual to be considered a genotype positive. As I just alluded to, not all the mutations are in the sarcomere. You also have mutations in the M band, the Z disc, even in the mitochondria of hypertrophic cardiomyopathy, which is different from syndromic LVH that can be seen in some of the storage diseases that can serve as masqueraders of hypertrophic cardiomyopathy. The thing to keep in mind is that there's significant variable expressivity, meaning the same mutation in the same family can cause a completely different phenotype. And here's just one proband showing the affected parent having an apical HCM with an apical aneurysm requiring an ICD, passing on the same mutation to two offsprings, one of which ends up having obstruction from SAM, which will be talked about later, and requiring a septal myectomy, while the other one also requires an ICD, but at this point they have what we call the reverse curvature subtype of LVH of HCM. So significant variable expressivity is noted, as well as the variable penetrance. And the reason for that is the same mutation can result in abnormalities in the cardiomyocyte, but in the heart we have the cardiomyocyte interacting with the interstitial matrix as well as the fibroblasts. And because of this multi-level interaction, different mutations can result in different types of phenotypic expression. More importantly, when you have these monogenic HCMs, meaning it's a myosin heavy chain 7 or myosin binding protein C, they tend to be extremely hereditary, and every generation is affected. But when you have sarcomere negative patients, meaning their genetic testing is negative, then we tend to call those polygenetic or polygenic. And those patients usually don't have significant family aggregation. So it could be just one individual involved in the whole family. Genetic testing, which is something that we do in all our tests, all our patients. You can have very broad cardiomyopathy gene panels. You can have detailed just hypertrophic cardiomyopathy gene panels. All of them have a diagnostic yield of about 30%. So just having a negative genetic test does not rule out hypertrophic cardiomyopathy. Well, the histopathology, so classically from medical school, we all know about the myocyte disarray and the disorganized architecture, which is associated with arrhythmogenicity. But there's also a new understanding of interstitial fibrosis and how that is really what leads to the hypertrophy in the heart, so to say. You also have microvascular ischemia that is really secondary to these thick-walled and very narrow-lumened arterioles within the myocardium. And then those can be in close juxtaposition to fibrosis on anatomic pathology. So it's really histopathologically a very, very interesting disease. And we'll talk about that later when we go over the MRI talk by Dr. Bishair, I think. So how to diagnose HCM? Well, you need to have some degree of LVH to diagnose most HCM. So you have to have more than 15 millimeters on an imaging study, whether that's echo usually, or cardiac MRI or CT. But it has to be in the absence of a secondary cause of LVH. So the patients should not have hypertension, no valvular stenosis of the aortic valve. And you need to think about the masqueraders, the infiltrative cardiomyopathies. And this here is just to show that what an abnormal LVH really does vary in the population. So one patient may have a thickness of 10 millimeters being very thick. Another patient may have a thickness of 25 millimeters, and that may be normal. So there are population references. The adverse pathways or the clinical manifestations of HCM can be asymptomatic. They can have obstruction, as will be talked about today in 2 different talks. They can be at risk for sudden cardiac death, and I will briefly go over that. They can actually have a higher risk of developing atrial fibrillation and systemic thromboembolism, or they can actually have advanced heart failure from HCM. So, like I said, some people may be completely asymptomatic. This is just a big cohort showing that 46% of their patients had no symptoms whatsoever. They were just incidentally diagnosed with HCM, and they did very well over a period of 10 years. The next largest group is the obstructive group, and these can have progressive heart failure, reduction in their NYHA functional class, symptomatic dyspnea with exertion. About 17% are at risk for atrial fibrillation and its complications. And then sudden cardiac death happens in about 6% of these populations. Like I said, obstruction is going to have its own talks, but basically you have hypertrophy as well as abnormalities in the mitral valve apparatus, resulting in a dynamic obstruction of flow across the LVOT, resulting in the pathognomonic echocardiography, as well as invasive cath lab findings. And this is seen in about 70% of patients, and it can be provoked or unprovoked or at rest, as will be talked about. The definition is more than 30 millimeters at risk. Now, why is it important? Well, obstruction does portend a really poor prognosis. So freedom from HCM-related death really does go down when patients have obstruction. And this is just the data from the US and from Italy showing the same thing. So obstruction does portend a poor prognosis. Different options for treatment, and this is just to serve as a teaser for what will be discussed later. Well, we have medical therapy and we have septal reduction therapies. They all have their positives and negatives, and we will go into those later. The thing to keep in mind is that if you go the medical therapy route, these are continuous therapies that have to be continued lifelong, while the septal reduction therapies tend to be a one-time therapy. There are non-LVOT obstruction subtypes. So you can have the RV being involved. You can have apical hypertrophic cardiomyopathy with an apical aneurysm over here. You frequently have abnormalities in the papillary muscles in their insertion or in their numbers in hypertrophic cardiomyopathy. This is a very often missed on echo entity, which is the deep myocardial crypts that are pathognomonic of hypertrophic cardiomyopathy. And then, like I said, that there's abnormalities of the mitral valve apparatus, including elongated anterior mitral leaflets. This is one patient with very clear apical hypertrophy with an aneurysm. That is much, much, much more common in Japan than it is in the US, fivefold more common. We see a lot of them here in the UAE. And why is it important? Well, if they have an apical aneurysm, then they are much higher risk of adverse events, including mortality, VT, VFib, heart failure, and thromboembolic events. So these patients need to be followed closely and be counseled about sudden cardiac death. If a patient has an LVEF less than 50%, then that qualifies them for advanced heart failure with hypertrophic cardiomyopathy. So they don't need to have an EF below 25% like the regular dilated cardiomyopathies to be considered advanced. And that is from this data here showing that they have a significantly higher number of sudden cardiac death events. A lot of them require transplants. Otherwise, they die from hypertrophic cardiomyopathy or just all-cause death. So be very careful of somebody who has hypertrophic cardiomyopathy that you're following where the EF drops below 50%. These patients are candidates for the advanced heart failure therapies, whether they be LVADs or heart transplant. There are potential complications in both cases, particularly because the ventricle is thick and small, but there are ways to get around that at centers of excellence. And when they get transplanted, hypertrophic cardiomyopathy patients do extremely well, primarily because they're younger and have less comorbidities. They do better than the ischemic cardiomyopathies and the non-ischemic cardiomyopathies after transplant. Sudden cardiac death, well, in athletes and competitive athletes, hypertrophic cardiomyopathy accounts for up to 42% of all the cases of sudden cardiac death during competitions. So it's something that we take very seriously in screening of athletes. There's a lot of pathophysiology that can, go into why this happens. Ischemia is involved, as well as abnormalities in the conduction system as well, and into intercellular calcium flow. But basically, these patients have a 50% chance of developing ventricular fibrillation, and the rest is all VT. So discussions about ICD are very paramount. Now, with time, we're doing much better in terms of the sudden cardiac death rates worldwide, a significant reduction throughout, including in Asia, United Kingdom, North America, and Europe with time. This is data over more than 20 years' time. And we're doing better in the terms of the hypertrophic cardiomyopathy mortality in general. This is early cohorts back in the 70s and 80s. These are more recent cohorts. The hypertrophic cardiomyopathy-related mortality went down from 3.6% to 1.5%. And now with the option of transplant and septal myectomies and septal reduction therapies, we've really brought down the death rate to 0.5% per year, which is actually lower than the general US population death rate. So in summary, hypertrophic cardiomyopathy is very common. The genetics can be either monogenic, which is where you have sarcomeric mutations, or it can be polygenic, where you don't have a positive mutation. The penetrance and the expressivity are very variable. Sarcomeric mutations will be inherited in an autosomal dominant fashion, so they will not skip a generation. You are encouraged to pursue genetic testing, but keep in mind that a negative test does not rule out hypertrophic cardiomyopathy. The main adverse pathways to think about with hypertrophic cardiomyopathy are obstruction, sudden cardiac death, atrial fibrillation, and advanced heart failure. Obstruction portends a very poor prognosis and requires therapy and diagnosis, and that will be covered in other talks today. Apical hypertrophic cardiomyopathy is much more common outside of the US, and the aneurysms really do portend a poor prognosis. Not all HCM requires LVH. You can have crypts or elongated anterior mitral leaflets. And then if a patient has an EF below 50%, take it very seriously and consider referring them to an advanced center. And with that, I thank you very much.
Thank you so much, Hussam. That was a very elegant overview, a lot of teasers, and it really sets the stage for the rest of the talks during this session. I'm sure there will be several questions. We'll take them. If you have any questions in the audience, please feel free to put them in the chat box, and we'll take it after the second presentation. Moving along, it gives me a great pleasure to introduce the next speaker, who is Dr. Bashair Ghayat. She is a woman of multiple talents. She's a multimodality cardiac imager. She's a speaker par excellence. She's interested in cardiac MRI. And with that, she will tell us more about the role of cardiac MRI in diagnosing and risk stratifying HCM. Bashair, take it away.
Thank you so much for the kind introduction, Firas, and thank you to all our attendees for spending the evening with us. So I'm delighted to speak about imaging in hypertrophic cardiomyopathy with an emphasis on the role of cardiac MR. See right over here, I have no disclosures related to this talk. So over the next 15 to 20 minutes, I'm hoping to highlight unique information that cardiac MR provides and how it influences critical decision-making in patients with suspected or established hypertrophic cardiomyopathy. And by the end, I hope we have a better understanding of when CMR should be incorporated into the evaluation of hypertrophic cardiomyopathy, which cardiac MR findings portend poor prognosis, how CMR helps us distinguish hypertrophic cardiomyopathy from the phenocopies, and finally, where the field may be heading in the future. So let's begin with one of the most practical reasons why we obtain cardiac MR and hypertrophic cardiomyopathy, which is wall thickness measurement. Maximal wall thickness remains one of the cornerstones of diagnosis, as Dr. Hussam very nicely highlighted in his slides. And while echo is the first-line imaging modality, it is well known that it may underestimate focal hypertrophy. On the other hand, overestimation can also occur, especially when we start to incorporate trabeculations or papillary muscles, or oblique imaging planes are included in the measurements. So one study showed that echo could underestimate maximal wall thickness by as much as 14 millimeters in selected patients. And importantly, these discrepancies are not just academic. And another study shown here, approximately 16% of patients crossed an important diagnostic or prognostic threshold depending on the imaging modality used. I wanted to also highlight echo blind spots in this slide. So there are several regions where echocardiography particularly misses focal hypertrophy. Some of those are the infrareceptum, the LV apex, and the anterolateral wall. And this is also one of the reasons why CMR is particularly valuable when clinical suspicion remains high despite equivocal echo findings. Now, it's important to emphasize that this is not an either-or discussion. In reality, echo and CMR are complementary modalities. Echo remains the cornerstone of initial assessment because it's widely available and provides excellent hemodynamic information, specifically with quantification of LVOT gradients at rest or with provocation. CMR, however, provides more precise assessment of wall thickness, as we mentioned, but also better characterization of complex phenotypes, superior visualization of the LV apex and lateral wall, and most importantly, tissue characterization, unfortunately, with the use of contrast, however, things like late gadolinium enhancement and parametric mapping. So essentially, and in reality, I think we should be using both. Now, although we often think of hypertrophic cardiomyopathy as this asymmetric septal hypertrophy, the reality is that hypertrophic cardiomyopathy is remarkably heterogeneous, as we see here. Now, the most common phenotype is the basal septal or sigmoid variant, and as we know, this is the one that's frequently associated with LVOT obstruction that I'm sure some of these speakers will touch up on later. But on the other hand of the spectrum, we also have the apical and focal variants, which can be challenging to detect on echo and may mimic hypertensive heart disease or athletic remodeling. And CMR allows us to appreciate the phenotypic diversity of this disease far more reliably than echo. And I'm hoping to show you some examples here of the phenotypes that CMR can uncover. I'm just going to play that bottom slide as well. So, and this slide here highlights the extraordinary diversity of the hypertrophic cardiomyopathy morphologies. In addition to the classic basal septal type, we can also see very nicely here the reverse curvature, which is associated with the sarcomeric genes, as well as this infraseptal focal hypertrophy, which, if we're looking at the four-chamber view, might be missed, and lateral wall hypertrophy to the right-hand side as well, and that classic apical hypertrophy. Another point that I wanted to highlight is the presence of RV hypertrophy, which is oftentimes missed on echocardiography. Now, this again is not pathognomonic for just hypertrophic cardiomyopathy. Other diseases can mimic this, but at least we can nicely appreciate this focal hypertrophy of the RV free wall, as well as this concentric RV hypertrophy in the bottom left side image as well. This was also touched up on. Now, historically, LVOT was thought to be primarily a consequence of, septal hypertrophy, but we now know that this is really a mitral valve disease, and papillary muscles can frequently contribute. And we can clearly see on this image that acceleration velocity in the LVOT, as well as that classically posteriorly directed mitral regurgitation jet. And we can plan as well as see the papillary muscle insertions there, which becomes very important when we start to discuss myectomy and surgical planning as well. Now, apical aneurysms are also something that CMR is superior at picking up over echocardiography, and it's estimated to be in approximately 1 to 5% of patients with hypertrophic cardiomyopathy, most commonly in association with the apical hypertrophic cardiomyopathy phenotype or the mid-cavity obstruction. And why does this matter? Well, more than half of these may be missed by echo, but also patients with apical aneurysms, as highlighted previously, are a distinctly high-risk subgroup. They have increased risk of ventricular arrhythmias and sudden cardiac death up to 5% per year, as well as thromboembolic events up to 1% per year. And in many ways, apical aneurysm is one of the clearest examples of how CMR can change risk stratification, but also management. And one of the complications we frequently identify on MR within these aneurysms is an LV thrombus seen in this LGE image right here. And we can appreciate these as, a hypo-intense area or non-enhancing area against a hyper-intense or enhancing myocardium that's filled with scar. So far, we focused on the diagnosis and phenotypes, and let's now move towards disease progression and risk stratification. Again, as mentioned, the development of LV systolic dysfunction, sometimes referred to as burnt-out hypertrophic cardiomyopathy or end-stage hypertrophic cardiomyopathy, although it's relatively uncommon in about 8% of all comers with hypertrophic cardiomyopathy, it portends a poor prognosis. And patients with extensive hypertrophy or pre-existing fibrosis, which we can see nicely on MRI, or sarcomeric mutations and prior septal reduction therapies, especially in the last 6 months, are at particularly increased risk of developing this. And CMR plays an important role by quantifying ventricular remodeling, scar burden, and systolic function reproducibly over time, which is great when you're serially following the patient. Unfortunately, once LV dysfunction develops, outcomes are often poor. More than 3/4 of patients will experience significant adverse events, and over 1/3 may ultimately require advanced heart failure therapies, transplantation, or mechanical circulatory support. And CMR is uniquely positioned to track this transition through serial assessment. One mechanism thought to contribute to disease progression is microvascular dysfunction. And I think this is highly underutilized when it comes to cardiac MR. So here is an example of a stress perfusion cardiac MR with stress images at the top. And we can appreciate this circumferential diffuse reduction in perfusions in the subendocardium, and particularly more noted in the areas of maximal hypertrophy when we look at the vasodilator stress imaging when compared to rest. And why this is important is because microvascular ischemia is thought to contribute to replacement fibrosis, progressive remodeling, ventricular dysfunction, and arrhythmogenesis. And in other words, perfusion abnormalities may represent an earlier stage in the pathway that ultimately lead to scar formation. Now, late gadolinium enhancement, or LGE, remains one of the most important contributions of CMR and hypertrophic cardiomyopathy. The majority of patients will demonstrate some degree of fibrosis, and typically LGE appears as patchy mid-wall enhancement, as we see in this slide, with a predilection for the hypertrophied segments, but also we tend to see this non-specific RV insertion point LGE pattern as well. Now, importantly, LGE represents replacement fibrosis and provides information that cannot be identified on echo or other modalities. And for many clinicians, this is where CMR truly begins to move beyond anatomy and into risk assessment. But over the last decade, we've learned that the amount of fibrosis may be just as important as its presence. And this has been incorporated in multiple sudden cardiac death risk calculators. So we now know that a fibrosis burden greater than 15% is the number to look out for when it comes to increasing sudden cardiac death, with some studies demonstrating up to a 2-fold increase in sudden cardiac death. And this has led many clinicians to incorporate fibrosis burden into discussions regarding ICD implantation, especially when traditional risk factors alone do not provide a clear answer for the patient. Now, historically, we viewed LGE as a static marker of replacement fibrosis or a snapshot, but more recent studies suggest that fibrosis continues to evolve in many patients with hypertrophic cardiomyopathy. And this study by Habib and colleagues that was published in 2021 demonstrated that LGE burden frequently increases over time, and that progressive fibrosis is associated with adverse remodeling, worsening ventricular function, and poorer clinical outcomes. So this raises an important question. Perhaps the question is no longer simply how much scar is present, but we should also be asking, is this scar progressing over time? And beyond quantifying fibrosis, cardiac MR can also provide important clues regarding the underlying diagnosis. And here we see some common examples. On the top left of the slide is normal homogeneous myocardium without any areas of white or late gadolinium enhancement. But also to the top right, we see that ischemic pattern or LAD chronic ischemia within what looks like an LV aneurysm there. And at the bottom, we see what we discussed there, which is just patchy uptake in the most hypertrophied segment of this reverse sigmoid hypertrophic cardiomyopathy. And finally, here we see this diffuse uptake of LGE, not only within the myocardium, but also the RV and the atria that we see classically with cardiac amyloidosis. And so CMR is central in helping us differentiate the phenocopies and decide what other investigations we want to pursue next. Another area where cardiac MR really shines is tissue characterization through T1 mapping and extracellular volume assessment. And these techniques allow us to move beyond morphology and assess the myocardium substrate itself. So different diseases occupy different regions of the T1 map and ECV spectrum, as we see here. For example, Fabry's disease typically demonstrates low native T1 values because of sphingolipid accumulation, whereas amyloidosis demonstrates markedly elevated T1 as well as ECV values due to extracellular protein deposition. And this capability is particularly important because not every thick ventricle represents sarcomeric hypertrophic cardiomyopathy. And increasingly, tissue characterization is helping us distinguish between these diseases that may overlap. Phenotypic overlap between cardiomyopathies is one of the most challenging areas in cardiovascular imaging, and it's really what keeps us in business. And I find that cardiac MR is the best modality to try to tease out these diseases. As we all experience in clinical practice, these entities rarely exist in these very neat diagnostic silos, and they often overlap, especially early in the disease course. And increasingly, we encounter patients who have overlapping phenotypes, whether that's early hypertrophic cardiomyopathy or athlete's heart or myocarditis, or rarely eosinophilic myocarditis. And so I find that incorporating cardiac MR function assessment, but also tissue characterization and LGE helps us narrow the diagnosis a little bit more in these gray zone areas. Finally, I want to move towards future direction. So as our understanding of hypertrophic cardiomyopathy continues to evolve, even our definition of the disease may need to evolve as well. Now, traditionally, the diagnosis has relied heavily on a maximal wall thickness threshold of 15 millimeters, but with increasing recognition, more people are moving out of that thought into a single cutoff because that may oversimplify a complex disease. Wall thickness is influenced, as we know, by sex, age, ethnicity, and patients' physiologic fitness as well. And so wall thickness by itself may not be adequate. And in the future, we may involve more individualized definitions of hypertrophy that are segment-based. And these two studies highlight why cardiac MR has become central to contemporary hypertrophic cardiomyopathy care. On the left, we see that even when we agree a patient has hypertrophic cardiomyopathy, how we measure maximal wall thickness matters. And this study demonstrated substantial variability in wall thickness measurements with the potential to influence ICD recommendations in approximately 1 out of 7 patients, depending on the imaging modality. And on the right, cardiac MR identifies apical hypertrophic cardiomyopathy that may not satisfy the traditional 15 millimeter cutoff. And so diagnosis becomes apparent because of the overall pattern of hypertrophy rather than exactly meeting that 15 millimeter wall cutoff. And perhaps the most exciting application for cardiac MR in the future is not diagnosis, but monitoring response to therapy. So the emergence of cardiac myosin inhibitors, which a lot of the speakers will focus on in the upcoming talks, may change this. The Explorer HCM and Sequoia HCM CMR sub-studies demonstrated evidence of reverse remodeling with mavacamten and aficamten therapy, and patients experienced reductions in LV mass, maximal wall thickness, left atrial size, and markers of adverse remodeling. And these findings suggest that we may be observing true disease modification rather than simply symptom improvement. And as these therapies become more widely adopted, serial cardiac MR may emerge as an important biomarker for treatment response in these patients. And so finally, I would like to leave you with these take-home messages. First, that cardiac MR defines diagnosis when echo is inconclusive or incomplete. CMR identifies important phenotypes that may be missed by echo, particularly apical disease and apical aneurysms. Fibrosis assessment has become central in contemporary risk stratification and hypertrophic cardiomyopathy. And CMR uniquely identifies high-risk features like extensive scar burden and left ventricular thrombi. And finally, CMR is increasingly influencing management decisions, not only through diagnosis and risk assessment, but potentially through monitoring therapeutic response as well. And thank you so much for your time and attention.
Another fantastic talk, Dr. Bashir. Thank you so much. I'd like to invite Dr. Nadia, Dr. Hussam to join us for the first Q&A segment. For the audience, if you have any questions, please feel free to put it in the chat box. And in the meanwhile, Dr. Nadia and myself will have a couple of questions to all the speakers. Amazing work. We've learned about how does this disease look clinically? How does the disease look with multimodality imaging lenses? I have a question for Bashir. Let's start with you.
Sure.
If you have a practice like ours, oftentimes we get different imaging studies, whether echo or MR, with an indication rule out HCM. And I followed Dr. Hussam's talk very closely, and yours, but there does not seem to be a single pathognomonic finding that makes me say there is or there is not HCM. So I'm curious to hear your thought process when you get such a study. What is your approach to decide, is this HCM, is this something else? What do you put in the report? Just walk us through your thought process, if you don't mind.
Absolutely. So I think the main difference between being a cardiologist looking at these studies is, first, I'd like to incorporate the clinical picture as well. I like to look at the patient's age. Younger patients, I'd like to also look into the notes to see if there's any suggestion of, are they an aerobic athlete, for example, which can explain some of these physiologic findings that can overlap with hypertrophic cardiomyopathy. And then when I start with my scout images, or what we call the mapping images, I like to get my 4-chamber LVOT, a few short axes, as well as 2-chamber views, and see if any certain wall segment catches my eyes. So, if you're getting the 4-chamber and you see that nice reverse sigmoid, then you're sure at that point that all the traditional sequences that you're going to get will cover your diagnosis. But sometimes it's not that obvious. Sometimes you pick it up on the LVOT view, where you can start to see that inferolateral wall that's more prominent. And so if I do see that, then I try to focus on getting more additional slices through there so I can measure the maximal wall thickness. It goes without saying that all of these cases I do include mapping, so pre-contrast and post-contrast mapping. I also include T2 mapping, especially when I'm thinking of the phenocopies, because occasionally in cases like amyloidosis or myocarditis, you can have elevated T2 mapping as well that can allude away from sarcomeric hypertrophic cardiomyopathy and more into those phenocopies. Having said that, though, sometimes end-stage hypertrophic cardiomyopathy can have elevated T2 values, and that's another prognostic factor. And I like to make sure that the patient has a hematocrit the day of, so I can accurately calculate that patient's ECV, which becomes very important in diseases like amyloidosis. Secondly, if I do see that LV aneurysm type or apical hypertrophic cardiomyopathy, I like to include early delayed enhancement sequences, not just late gadolinium enhancement, because sometimes, depending on where you are on the acuity of the thrombus formation, you can pick these up in EDE images or early delayed enhancement images, which can be missed sometimes on LGE if they're quite small. And some of these, specifically recesses, in some of the examples that Dr. Hussam showed us in his slides as well. And that's the approach that I typically take with these patients.
Great. This is very helpful, Bashir. Thank you so much. Hussam, any additional comments from an imaging standpoint?
No, I can't follow Dr. Bashir and add more, but It really does help when you have somebody with direct cardiac imaging exposure. It helps if they're a cardiologist, but if not, if they're a dedicated cardiac imager, it does help in terms of how the sequences are taken. You end up having less back and forth discussions about why there was no parametric mapping. Where was the LGE in comparison to the LVH? You want to see clear patterns going together, especially with all these masqueraders. But it is very, very important to get these right because we only do the MRI every 3 years or so. So if you take one bad snapshot, it can send you on the wrong pathway for these patients. That's all I would say.
Yeah, very well said. I think this brings to the forefront the importance of, not just doing the imaging studies, but properly interpreting them in the context of the findings, whether you as a reading physician or as a treating physician. It really needs to be put within the context of the clinical findings. Dr. Nadia, do you have any comments or questions for the speakers?
There is a question from the Q&A. It's directed to Dr. Hussam. So they ask for, from your current practice, what's the prevalence of non-sarcomeric HCM versus sarcomeric?
Sorry, Dr. Nadia, I lost you for a
We
second.
lost.
But let me go in the chat. Is it in the chat? Is it in the
Yes.
chat? Mhm.
Yeah, Hussam, when the Gulf patients undergo genetic analysis, do you notice more non-sarcomeric versus sarcomeric variants within the Gulf population? I guess that's the essence of the question.
I have so we have the Cardiomyopathy Center that all of us are
When the
engaged.
Gulf patients undergo genetic analysis.
So I think there was a glitch. So I'll answer saying that we're not seeing actually a very high preponderance of the sarcomeric mutations here, which is very surprising and is very thought-provoking and hypothesis-provoking. So we plan to actually study this at a genetic level with the help of our colleagues in the Genome Project as well, because we're not seeing that direct reverse curvature myosin heavy chain 7 mutation that we used to see in the States. We're seeing a lot more apical HCM here as well because of the military screening and the competitive athlete screening. So that tends to skew the genetic prevalence of these mutations that we talk about as well. Surprisingly, I see a lot of the TNNT2 mutations in the UAE, specifically in the local patients, more than and they tend to have a lot more advanced heart failure compared to the sarcomeric. I don't know if Nadia or Faraz or Bashir, if you guys want to comment on that.
Yeah, I agree with you, Hussam. Yeah, especially because they're doing like a military screening. So now we notice that there's a lot of younger people who have like HCM, and they're asymptomatic. But unfortunately, when we see them in the clinic, they're really in advanced heart failure. I think a couple of them, we listed them for transplant, and so my next question to you that. What's your advice to any cardiologist who will see an HCM? What's your approach to the patient about the screening?
Hypertrophic cardiomyopathy is very common, and it cannot be managed by centers of excellence. We don't have enough cardiologists to do all of that. So the general cardiologist needs to be very familiar with the initial screening for these patients. So a good echocardiogram, being at a center that can do a good cardiac MRI. If you don't have good cardiac imagers in your MRI, it's probably better not to do the MRI there. It's probably better to refer for the MRI to a center like Bashir's or like our center, and then get the patient back. A good 3-generation family history is very important. Looking into the masqueraders, so you ask about hypertension, you ask about anabolic steroid abuse. These are things that can be causative as well. And then doing a sudden cardiac death risk assessment, which really depends on the age. Young patients, it's a bit difficult, and they have their own scores, adolescents. But in adults, you want to do an exercise stress test and a Holter monitor. Those are usually the beginnings of it. And if you see any signal there, then you can get a second opinion from a hypertrophic cardiomyopathy center of excellence, where they will evaluate the patient once or twice and then return the patient back to you for follow-up.
Yeah. I think there's a question also, one more question to you for Dr. Ghanem. Can't see the one. Firas, can you see the question? Yeah.
Yeah, there is a question to Bashar. Go ahead, Nadia.
Bashar or for Hussam? There's two questions. One for Dr. Bashar. Okay. So, question Dr. Bashar, importance of LGE and how to differentiate between the LGE due to HCM versus non-HCM, such as Fabry's or cardiac amyloid.
That's a great question because I think that's the easiest thing that cardiac MR can answer for you. So generally speaking, Fabry's is the easiest one to kind of put aside. With those patients, as you know, it's mostly sphingolipid deposition. And so with that, you see low T1 values, and that's one of the fewest diseases that can cause that on cardiac MR. And obviously, the cardiac imager reporting it is responsible on letting you know that this is low for that type of magnet and the lab validated values as well. So that answers Fabry's. Then when I look at amyloid versus hypertrophic cardiomyopathy, amyloidosis is more of a systemic disease, and quite frequently the earliest signs will be atrial deposition. So a lot of the times, if you scan these patients early, what you'll notice is that there's actually more LGE around the atrial walls and sometimes on the surfaces of the AV valves as well. And it's more diffuse uptake. Oftentimes, when people are not adequately trained, they even think that they've got the nulling time incorrectly and they've done their LGE images incorrectly, because it's kind of hard to differentiate myocardium from blood pool just from how diffuse the amyloid process is due to abnormal protein deposition. With hypertrophic cardiomyopathy, especially if you catch those early, you may not even find more LGE than that non-specific RV insertion point LGE, which can be seen sometimes in hypertensive heart disease as well. And that's why it's important to also put it in context of the clinical picture. So if this is a 60-year-old with resistant hypertension, CKD, there's only RV insertion point LGE, ECV, T1 time is normal, then that's more likely hypertensive heart disease than sarcomeric hypertrophic cardiomyopathy. For hypertrophic cardiomyopathy, what we traditionally see is that mid-wall patchy uptake within the most hypertrophy segment. So when I see my cine images and I notice that this is where I'm going to be measuring because that's the thickest wall, that's where I focus my attention on when I'm doing my LGE images.
So, did you start the second session, Firas and Hussam and Bashar, and then we can continue with the questions, I think. So now it's my pleasure to introduce my colleague, Dr. Firas Al-Badreen. He's a cardiologist and multimodality cardiac imager with interest in cardiac amyloid and cardiac bed. And he's going to discuss about the state of the art medical therapy for HCM. Dr. Firas.
Thank you so much, Dr. Nadia. Do you guys see my screen?
Yes, we can see it.
Do you see presenter view or no?
No.
Okay, thank you so much, Dr. Nadia. And this has been very exciting and very informative discussion. We've talked about how to pick up the disease clinically, how to pick it radiographically, and now that we have the diagnosis, how do we treat this disease? That's going to be the focus of the second session. And I've taken on the daunting task of talking about the state-of-the-art medical therapy of HCM in 2026, which is beyond what you can cover in 15 minutes. But let me try just to give you an idea. Dr. Hussam has very elegantly discussed the pathogenesis of HCM. I just want to build up on that and add another aspect, which is which we've recently learned about the impaired energetics in the myocardium of patients with HCM, such that their ability to maintain the ATP in the triphosphate state is so impaired that they tend to lose the third phosphate group, and which leads to priming of the myosin head and move them from the relaxed form that you see here to the bound and the power stroke position. So once they hydrolyze and lose the phosphate, and it binds to the actin, and the sarcomere goes to the on position. And this is very important because that's exactly how the myosin cardiac inhibitors, mavacamten and aficamten, work, by slowing this myosin hydrolysis and keeping the ATP in the triphosphate state, which keeps the myosin head in the relaxed form. So this is a new.
I don't think we don't see your slides for us.
Yeah.
You don't
Can you
mind.
share, please? There's like
You see it now?
No. Yes, no.
Yes.
Okay. All right. Sorry about that. So I was just explaining how the impaired energetics work in HCM, and the role of myosin inhibitors in maintaining and reversing this central mechanism. We've seen how patients with HCM present. What they tend to present with is heart failure, either from impaired cardiac output and LVOT obstruction, or in advanced cases from impaired contractile function. They can have angina due to a variety of mechanisms that have been described. They are at risk for arrhythmias, atrial fibrillation being the predominant form, and sometimes they can have fatal arrhythmias that can lead to sudden cardiac death and increased risk of mortality. So when we try to manage these patients, what we try to do is to cover these pillars, to talk about sudden, those are the four tenets in HCM management. Assess the risk of sudden cardiac death and act accordingly. We will briefly touch on that. Decide whether the patient is obstructed or non-obstructed and provide the appropriate treatment, and assess the risk and the presence of atrial fibrillation and provide necessary anticoagulation, as we will see. Let's start with LVOT obstruction. The ACC guidelines in 2024 clearly shows that patients who have symptoms secondary to LVOT obstruction are candidates for non-vasodilating beta blockers as a first line of therapy. And just want to draw your attention here that the level of evidence is being non-randomized. This has always been our first line therapy in patients with symptomatic obstructive HCM, despite the absence of randomized evidence showing the efficacy of this class of medications. And now, if you look at the third box, that patients with symptomatic obstructive HCM who have residual symptoms despite adequate beta blockade, those are the patients who we would consider the addition of myosin inhibitors in adult patients. The European guidelines have taken a slightly different stance, and they still recommended beta blockers as the first line of therapy for symptomatic obstructive HCM patients, and they gave the addition of myosin inhibitors, mavacamten, as a 2A recommendation in patients who have residual or persistent symptoms. But it is really important to understand in this day and age that the introduction of myosin cardiac inhibitor has really changed the way We understand HCM, the way we treat patients with HCM, and these disease-modifying therapies have really shifted the center of gravity away from beta blockers and other rate-slowing medications as the first line of therapy. And when we talk about cardiac myosin inhibitors, we talk about mavacamten and aficamten. Mavacamten was studied in the pivotal study in the Explorer HCM that really took 250 patients with symptomatic obstructive HCM and really showed that by randomizing them to mavacamten, there is a higher improvement in exercise tolerance and significant reduction in rest and exercise LVOT gradient compared to placebo. So you abolish that LVOT gradient, you've shown that quantitatively, and you also improve their exercise tolerance, which are important, two important endpoints when we care for these patients. And when the MAVA LTE study, that's the open label extension, they looked at a longer duration. They showed that there is persistence of this advantageous effects of mavacamten on LVOT gradient over a duration of 84 weeks. So this is something that is durable and long-lasting. How do patients feel while on mavacamten? They feel better. And this is data from the quality of life sub-study of the Explorer HCM that showed that patients on average get about 10-point increase in the KCCQ summary score when randomized to mavacamten compared to placebo. And when they are taken off therapy, this benefit goes away, further giving credence that this improvement in quality of life is due to the intervention. And if you look at patients who get large to very large improvement in their quality of life, there are threefold increase in the likelihood of achieving large or very large improvement with mavacamten compared to placebo. So the hemodynamics get better, exercise tolerance gets better, and also quality of life improves. What happens to biomarkers? They are reduced significantly. This is, again, a sub-study of the biomarker sub-study from Explorer HCM that shows there is about a 75% drop in NT-proBNP in patients randomized to mavacamten, and a similar pattern was also seen with high sensitivity troponin. So there is something happening at the cellular level where there is less myocardial injury and perhaps there is less myocardial stretch and better remodeling. These patients were, as you will hear from Dr. Zidane in the next presentation, were typically referred, those patients who have symptomatic obstructive HCM despite therapy are referred for septal reduction therapy. And that was the essence of the Valor HCM study that showed patients who are treated with mavacamten are more likely not to meet criteria for septal reduction therapy, meaning that if you have a patient who is symptomatic, you can avoid the need to refer them for septal reduction therapies, whether we're talking about myectomy or alcohol septal ablation, which brings up to discussion the role of septal reduction therapies in the CMI era. Sequoia HCM studied the other cardiac myosin inhibitor, aficamten, a similar study design, 282 patients with symptomatic obstructive HCM. Again, you see improvement in oxygen consumption, which indicates improvement, which is a corollary for improvement in exercise tolerance in patients randomized to aficamten compared to placebo. And there are similar studies that showed improvement in quality of life that I will not show for the sake of time. So what about the first slide where I showed you that the first line is beta blockers? How do beta blockers compare to CMIs in this day and age? This was the focus of the Maple HCM study that took 175 symptomatic patients with obstructive HCM and randomized them either to aficamten as a first line or metoprolol. and looked at their change in MVO2 at 24 weeks. And lo and behold, there is significant improvement in LVOT gradient with aficamten compared to minimal change in LVOT gradient in patients randomized to metoprolol. And we look at peak oxygen consumption, there is actually improvement in oxygen consumption with aficamten, but there is reduction in MVO2, peak MVO2 with metoprolol. So this really challenges the issue about the dogma that beta blockers should be the first line of therapy. So we've covered the role of CMIs in obstructive HCM. What about non-obstructive HCM? It is less clear, and the jury is still out. There's plenty of data, but suffice it to say that available data from mavacamten, there's Maverick HCM, there's Odyssey HCM, really showed that these patients don't derive as much benefit from CMIs if they don't have LVOT gradient. There is emerging data from both agents, but the jury is still out, as I said. So how do you treat HCM patients? Let's try to summarize and synthesize this. If you have a patient with hypertrophic cardiomyopathy, if they are non-obstructive, their first line of therapy is beta blockers and non-dihydropyridine calcium channel blockers. If they have congestive symptoms or if they have hypertension, you want to treat them and use ACE inhibitors and diuretics. On the other hand, if they have obstruction, the role becomes for beta blockers, maybe CMIs upfront for treatment of symptoms, and then you consider referring them for septal reduction therapy if they have persistent symptoms. Unlike non-obstructive patients, you want to avoid diuretics, you want to avoid dehydration, and you want to avoid direct vasodilating agents that decrease preload and actually worsen LVOT gradient. And those are very important distinctions when you manage obstructive and non-obstructive patients. What about the risk of sudden cardiac death? That can be a full session on by itself, but suffice it to say that you want to follow a risk stratification calculator or a scheme, and there are plenty of data on the role of age, markers of cardiac remodeling, septal thickness, presence of LGE, etc. And those can give you a predicted risk of sudden cardiac death. And according to this, if the risk is very high, basically you recommend ICD implantation for these patients, and if the risk is low, you recommend against it. What about in gray zone? That's when you start to incorporate phenomorphological variables that can help guide you or move you in one direction or the other. For example, as Dr. Abashair and Dr. Hussam said very clearly, apical aneurysm, extensive LGE, all of these are markers of increased risk, and they're genetic pathogenic variables that predispose these patients to increased risk of sudden cardiac death, and hence ICD implantation would be recommended. I'll close also with the role of anticoagulation. As I said, atrial fibrillation is a very common arrhythmia in these patients. And in essence, it is very simple. If there is an HCM patient who has clinical atrial fibrillation, anticoagulation is recommended, regardless of their CHA2DS2-VASc score. There is no role for risk stratification of CHA2DS2-VASc. If you see AFib with HCM, you start them on a DOAC, and that's a class 1 recommendation according to the ACC guidelines. A lot of these patients end up with devices, whether ICDs or pacemakers. What if you see subclinical AFib? Again, there's a class 1 recommendation. If you see AFib episodes lasting for more than 24 hours, to start these patients on DOAC in preference over a vitamin K antagonist. What do you do if somebody has 5 minutes to 24 hours? It depends. You individualize your decision and you weigh their risk, bleeding risk, thrombotic risk, other medications, and so on and so forth. Are we done with HCM? The answer is no. There are some remaining gaps that really require additional high-quality data, but the coming years are very exciting in the HCM space. Therapeutic sequencing in obstructive HCM. Will CMIs continue to be as an add-on therapy, as is the case in current guidelines, or will they move as a first line? I personally believe that the quality of evidence will soon become sufficient to recommend CMIs as first-line therapy in symptomatic obstructive HCM patients. The other area, what is the role of CMIs in non-obstructive HCM? And again, this is a very exciting space. There are a lot of high-quality data coming out, and I'm very optimistic that soon we will have evidence-based answer for this question. And I really would like to see genotype and phenotype-directed therapy for heart failure. As Dr. Hussam elegantly described, this is a heterogeneous disease with multiple genetic mutations, with multiple morphologic patterns. Does it make sense that we treat all of them with the same combination of pills? To my mind, the answer is no. And there needs to, at some point, that we direct our therapy to the presence or absence of the genotype and the presence and absence of certain phenotypes. But we are not there yet. So as I close, I would like to say that contemporary HCM management 2026 has shifted away from rate control and rate-slowing medications to the use of disease-target sarcomeric modulation with the cardiac myosin inhibitors, mavacamten and aficamten. These are really game changers and have really changed the way we understand and we treat HCM. Symptomatic patients with obstructive HCM, CMIs relieve obstruction, improve exercise tolerance, alleviate symptoms and improve health status, and promote reversal of cardiac remodeling, as was shown by Dr. Abashair. And the role of CMIs in symptomatic patients with non-obstructive HCM is less clear and remains as an open question, but there are ongoing studies that hopefully can illuminate this space very soon. DOACs are the backbone of stroke prevention in HCM patients with AFib. And once again, this is a complex disease that requires multidisciplinary care and requires proper risk stratification, not only for prevention of serious arrhythmias and sudden cardiac death, but also for choosing invasive procedures, as we will see in the next presentation. With that, I close and I thank you for your attention.
What a wonderful, wonderful whirlwind of therapy for HCM, Dr. Firas. Thank you very much for that. So now we will jump from medical therapy to procedural therapy. And it gives me a tremendous pleasure to introduce Dr. Mohammed Zaidan, our dear friend and colleague, to walk us through the advances in that field.
Thank you so much for having me. It's a pleasure to be with you all, Firas and Hussam, dear friends. I hope you see my slides okay? Okay.
Yes. Yes, perfect.
It's very exciting times for hypertrophic cardiomyopathy. For a long period of time, it was the orphan of cardiology, but I think myosin inhibitors brought it again under the microscope. It's very exciting. For the first time, we have a disease-modifying therapy. Now, Firas I know he doesn't like interventions much, so he's going to make the case that, okay, we don't need surgical reduction anymore, but I'm going to try to prove that there's maybe still a little bit of a role for surgical reduction therapies. HCM is unfortunately, very under-diagnosed and very under-treated. We know, let me just move my slides so that I see my slides better. Okay. We know for 70% of the patient have obstructive hypertrophic cardiomyopathy with a gradient more than 30 millimeter at rest or provoked with exercise. and that increased their symptoms, and also it correlates also with their mortality risk. Something to highlight, and I know probably the previous presenters highlighted, just making sure we check for the gradient on those patients, especially with exercise, as many of those patients may get missed with a very with the gradient being not recognized with exercise. How do we determine the success for any therapy? Success of any therapy is determined by the patient. If they feel better, they are doing more, then treatment is successful. We know for a surgical reduction therapy, we have myomectomy and alcohol septal ablation. We know that both of these therapies provide significant gradient reduction, 90 to 95% of reduction of heart failure symptoms over the long period of time, highly favorable long-term survival, low procedure mortality if less than 1% of performed in experienced center. Of course, there is a greater risk for permanent pacemaker and repeat procedure with alcohol septal ablation versus myomectomy, but of course, a shorter recovery and length of stay. We know, for example, with myomectomy that there is a permanent and complete normalization of LV pressures over long-term follow-up up to more than 11 years in those patients. Now, with cardiac myosin inhibitors, we know in around 70% of the patient there is complete obliteration of LV outflow gradient. 65% of those patients experience a clinically meaningful improvement and limiting symptoms. About 50% experience clinically meaningful improvement in functional capacity. We know that it is safe, well tolerated. We have between the studies 3.5 to 10% cause reduction in EF, less than 50%. So, what is the right treatment for those patients with obstructive hypertrophic cardiomyopathy? Is it myosin inhibitors and myectomy and alcohol septal ablation? Either one of those? I think this question is when we look at it, we have to look at each patient individually. We know with the guidelines, as Firas mentioned, mavacamten and myosin inhibitors are not first line, and I think they probably will be in the future. We know that they are not the magic pill for all the patients, because we know in around 35 to 40% of patients who are on myosin inhibitors, there's no change in NYHA class compared to 5% with surgical reduction therapy. There is around 30% of those patients still have some residual LVOT gradient, whereas it is less than 5% with surgical reduction therapies. Mortality is reportable with myosin inhibitors. It's 1%, and of course, it's higher in lower volume centers. Long-term efficacy is still a newer drug. We are hopeful. We still have to know over 5 years, 10 years, 15 and 20 years. With myectomy and alcohol septal ablation, we know that the LV gradient changes are durable more than 10 years. Myosin inhibitors, they don't require a lot of expertise, although you have to be careful how you titrate the medication, check their liver clearance and serial echoes. But for myectomy and alcohol septal ablation, you need a really high selective center with high volume, because that really affects the mortality and the outcome of the procedure. We know with myosin inhibitors, there's a lot of drug interactions, where with myectomy is one-time procedure. With myosin inhibitors, you're not able to address other cardiovascular lesions, whether it's PAP muscle abnormalities, mitral valve problems, where you can address that with myomectomy, mainly with surgery. We know there are subset of obstructive hypertrophic cardiomyopathy in whom the LV outflow anatomy may not be very amenable to optimal lowering of gradient with drug therapy. Patients with long anterior mitral leaflet, patients with very narrow LV outflow tract, those patients may not benefit as much from myosin inhibitors as with the reduction therapy. So, what really affects your choice one side over the other? What favors the surgical myectomy or alcohol septal ablation. Patient preference is one. I'm not going to take a medicine for the rest of my life where I can have a surgery and then I can have a relief of symptoms. Some of those patients remain eligible for septal reduction therapy despite myosin inhibitors, around 15%. If you have coexistent cardiovascular lesions, around 10% of patients with hypertrophic cardiomyopathy, patients who really don't have access to myosin inhibitors, drug is not available or it's very expensive, those patients definitely surgical reduction therapy can be considered in these subset of patients. I don't think that surgical reduction therapy will go away. It will be expanded more in conjunction with myosin inhibitors together. We know that where you have your surgical reduction therapy, the septum reduction really affects the outcome. For example, the myectomy between an experienced center versus low experienced center, the mortality is between 10% to around 0.6%. Same with alcohol septal ablation, 3% mortality versus 0.6%. So really having a good tertiary care center where you have a specialized hypertrophic team from imaging, from interventional cardiology, surgery, general cardiology, where those patients are treated in a multidisciplinary approach is key. Now, what's happening with surgical reduction or septum reduction therapy? There are new, very promising techniques. One is Sesame, which is really developed by one of my mentors in the States, which is Dr. Greenbaum. Septal scoring along the midline endocardium, which is mainly using electrosurgical laceration of the septum. The rate of pacemaker is less than 2%. It's still a very early procedure, really done in few centers only. There is a very promising surgical technique, which is transapical beating heart septal myomectomy, where the procedure is done on a beating heart without bypass, TEE guided, and the outcome in experienced center is really great. Those patients don't have like an open sternotomy. So there's definitely these procedures that can also provide another dimension for septal reduction surgery to make it more effective and safe and shorter surgery. So in conclusion, the majority of those patients obstructive hypertrophic cardiomyopathy, I think the myosin inhibitors will be first line in most of those patients, not all of those patients. You're gonna still have some patients despite myosin inhibitors based on anatomy, response, residual gradient, that they will still be candidates for septal reduction surgery. The treatment will help in symptom relief, and also it will reduce mortality. Individual decision making, of course, taking into account the patient clinical profile versus treatment goals, along with the center expertise and the patient desires. All that will play into action. Right now, I think we have a lot of tools. Dr. Bashar beautiful talk about MRI and the use of MRI in planning for those patients. We have new techniques, and I'm very happy actually that we have access to a disease modification therapy. It's very exciting actually, and I'm hoping like down the road in the future, definitely we'll have more of these treatments with time. But I'm sorry, Firas, I think there's still some role for alcohol septal ablation and surgical myomectomy. Thank you very much.
Thank you so much,
Dr. Zaidan. Thank you very much for this talk. So I think we will jump to some questions. So there's a question from the audience. It's basically asking, and the question is directed to Dr. Firas. How long should a patient be on non-vasodilatory beta blocker before jumping to a second line of an antihydropyridine calcium channel blocker? Basically, the nuances of the initial therapy before jumping to a cardiac myosin inhibitor? If you want to take that on, Firas.
I'm going to modify the question, and I would say if you don't have access to CMIs, or if a patient cannot afford them, and you're left with other non-disease modifying options. I would say titrating these patients over a couple of months. You start them on beta blockers if you don't have access to cardiac myosin inhibitors. Because you're affecting the hemodynamics, these patients can see improvement rather quickly. So if you start them on treatment and you don't see improvement in a window of 4 to 6 weeks, I'm inclined. That's what we did before the CMI era. We titrate them, or we add second class in 6 to 8 weeks.
Yeah,
Has that been your experience, Hassan?
I'll add a little bit. So, the patients are very heterogeneous, and their response is very heterogeneous as well. So, you really get a good sense. You have to get a sense before starting therapy of how symptomatic they are. And if there's any concern that you don't have a good handle on their symptoms, to actually get ancillary symptom-based testing. So, cardiopulmonary exercise stress testing, or 6-minute walk test, or exercise physiology, whether invasive or non-invasive, really helps you a lot. Because you're talking about lifelong therapy in these patients. So if you have somebody that you can prove is asymptomatic, in spite of having a high degree of obstruction, we've had actually the experience of waiting, watchful waiting, follow them very closely, and seeing when and if they develop symptoms. The gradient itself is very prognostically indicatory, but that it does not trump symptoms. So symptoms still are the most important factor. And you try. Some patients don't tolerate the bisoprolol; they tolerate the metoprolol. Some patients do very well with verapamil. We have a very good experience with disopyramide, actually, in getting rid of the gradient or reducing them, or reducing the symptoms. You do have to have a washout period for disopyramide if you use it. So you can't jump straight from it to the currently available mavacamten. And you involve the patients in the decision making. That's the important part of this disease, because all medications come with side effects and follow-ups, and so on and so forth. We have another question to Dr. Zaidan. Could you shed light on the coexistence of cardiovascular lesions in HCM? So what other lesions can septal reduction therapies deal with that CMIs may not?
So mainly mitral valve problems, especially if you have an abnormal leaflet, significant MR, that can be addressed during myomectomy. There is a significant amount of anomalous coronary arteries that come with hypertrophic cardiomyopathy. So this is also something that needs to be also addressed in some of those patients. And of course, if you have coronary artery disease, which is very common, hypertrophic cardiomyopathy patient definitely can still have the typical coronary disease, but it's mainly mitral valve pathology.
Excellent. Sometimes some patients have aortic valve pathology from the dynamic obstruction, and that may require to be surgically addressed as well. We have two comments talking about how surgical myectomy in good hands can have a very low mortality, and that's very true. They just have to be performed at centers that are doing quite a bit of them per year. And then the last question from the audience is to Dr. Firas. Mavacamten or aficamten, if both are available and free of charge and covered by insurance, and the patient does not want to undergo septal reduction therapies, which would you choose?
Well, I always like to provide evidence-based answers to these kinds of questions, and I would say that the preponderance of evidence is that both agents did well in terms of improving hemodynamics, improving exercise tolerance, improving quality of life. So in the absence of any head-to-head comparison, I don't think we can provide an evidence-based answer to choose one agent versus another. There are some analyses of aficamten in from phase 2 study, Redwood, that showed there's some symptomatic improvement in non-obstructive HCM. There are also data that from a larger study, again showing improvement, but this has not been peer reviewed and published, has not been published in peer reviewed literature yet. So in order not to base our recommendations on top of the line presentations or publications, I would say that both agents have done well. And the most common phenotype of HCM, which is obstructive HCM, and I would say that they're likely depend on availability, insurance coverage, and so on.
Excellent.
Sam, can I just say one thing? Mohammed, all joking aside, when we design these sessions, the intention is to come with provocative titles and so on, and how one treatment will abolish the other. But in reality, I think there is a role for in select subgroups. There is still role for septal reduction therapies in the situations that you mentioned. And that really, I want to put a plug for the MDT and the multidisciplinary nature of HCM. You really need a comprehensive assessment. You really need somebody like Dr. Bashair to give you an assessment of their imaging. Somebody like Dr. Nadia and Dr. Hussam to give you a clinical evaluation about their symptomatology and their degree of their impairment. And somebody with procedural and surgical expertise like yourself, Dr. Muhammad, to say whether there is an incremental benefit from an invasive option beyond what medical therapy can offer. I agree with Hussam that these patients are abundant, and not all of them can be cared for at tertiary centers, but these decision nodes perhaps need to happen at centers of excellence for HCM, and then the care can be turned over back to their physicians. Any comments from the panelists about this?
I really second what you mentioned, Firas. I think hypertrophic cardiomyopathy is not one disease. It's a spectrum. And where we are on that spectrum, it needs like a really good experience. We are not screening enough. We are not really treating enough, screening those patients, making sure that we check them for gradient. I see a lot of patients with hypertrophic cardiomyopathy labeled non-obstructive, where in fact no one put them on the treadmill to check like a provoked a gradient. Having access to a disease modification therapy now, it's really exciting because, to be honest with you, alcohol septal ablation is a barbaric procedure coming from an interventionalist. You're really causing an MI. I've seen, when we do it, patients have like really bad chest pain, probably between 10 to 20% end up with a pacemaker. Surgeons, it's not easy to find a surgeon who's really well experienced with shaving the septum, making sure that you get a good outcome. So I think I'm very happy that we have access to be the answer, but it is going to be really of help to many patients. I have a couple of patients who their really symptoms and their gradients and their NYHA class day and night, and they were like max and beta blocker, and they were like feeling miserable. So, and they're like young females in their 40s. So I think it's very exciting time for hypertrophic cardiomyopathy.
Agree. Any last words of wisdom, Dr. Hussam, Dr. Bashair?
There's always power in teams, as you mentioned. There's power in listening to your patients and listening to their symptoms, listening to how they tolerate your medications. So don't focus just on the gradient, focus on how well they're responding, what they're able to do. Don't give up on any of the therapies in different combinations, which has not been studied in the trials, as you mentioned. And get a second opinion. We get a second opinion even in our center frequently amongst each other. Refer the patients to somebody else to think about it. Because some of the decisions can be very, very important decisions for these patients. They're young. This is a young disease. Amyloid is an older disease. This is a younger disease. So make sure you get it right. Make sure you get it right the first time so that the patients do benefit.
Agree.
And the one last message from me, first of all, everyone summed this up very beautifully. So just to keep it brief, before you send a patient for ICD placement, please consider CMR, because the images won't look any more prettier than they already do before the ICD is in place.
So
Point
for
very
me,
well taken.
yeah, for me, they will add that I think we have to take a good history, and we have to ask about the family history, like a 3 generation, because usually, especially in our region, people, they don't know their family history of sudden cardiac death, because that will guide us when for like to diagnose. Yes.
Another very good clinical pearl. I've learned a lot from each one of you guys. There's been a lot of wisdom exchanged and a lot of knowledge. It is 9 o'clock. And with that, I would like to thank the speakers and the moderators for their time and expertise. I would like to thank the audience for sharing with us their time this evening. I would like to thank the organizers for their perfect organization for this event. And with that, I would like to close this event, and until we meet again in another webinar from Emirates Cardiac Society, please be safe. Take care.
Thank you.
Bye-bye.
Thanks, everyone.
Take care.
Good.